Thank you for the opportunity to speak today. My name is Kaavya Paruchuri. I'm a clinical and research cardiologist at Massachusetts General Hospital. My work focuses on the intersection of digital health tools, such as apps, wearables, and telehealth with precision genomics. The goal of my work is to improve patient risk prognostication and care delivery, particularly focusing on under-recognized populations such as women. I have no relevant disclosures for today's talk. I'm going to start off by giving a brief overview of heart disease in women and then highlight some of the gaps in current care systems. I'm then going to give a broader review of current digital innovation and end by focusing on strategies and opportunities for patients as well as healthcare providers to utilize these technologies going forward. First, I want to take a moment to discuss why heart health is important not just for cardiologists, but for everyone. Heart disease is incredibly common in the US, with over 60 million women currently living with at least one heart condition. As you can see here in this bar chart with women in red, you see that over half of the women between 2009 and 2012 were surveyed self-reported the prevalence of at least one cardiovascular heart condition, such as coronary heart disease, heart failure, stroke, and hypertension. In addition to being incredibly common, heart disease is often very deadly. Here you see a plot showing deaths due to cardiovascular disease for both men and women over time from 1900 to 2010 along the x-axis with mortality on the y-axis. You see a dramatic rise in deaths with a peak of more than 1 million deaths per year in the late 1960s. And this mortality is somewhat improving with the advent of more screening, prevention, and treatment. But as you can see here, despite the strides, mortality remains high through 2020. This plot is still showing mortality in the y-axis, but now I split the rates to show individual curves for women in red and men in blue. And notably, cardiovascular disease mortality in women is exceeding that of men from 1984 to 2012. Worse, despite some improvement in early 2000s, cardiovascular disease mortality is again increasing in both sexes, and it's up almost 7% in women in the past decade. Therefore, it shouldn't be a surprise that heart disease is the number one killer of women. However, in 2020, when women were surveyed, here you can see 2009 in white on the left side versus 2019 in gray. There was actually a decreased understanding of heart disease being the leading cause of death in women, with only 43% of population acknowledging heart disease as a primary risk, despite the fact that roughly 1 in 5 women that year died of heart disease. This is dramatic and concerning, given that awareness of heart disease has been tackled as a national effort through various awareness projects, such as Go Red for Women and Women's Heart Health Month. And February is actually Women's Heart Health Month, so I'm very happy to be discussing this today with you. We've had many efforts to try and understand how and why heart disease behaves differently in women compared to men, and genetics causes are an obvious first target because it's been successfully applied in many other fields. Genomic identification of risk is promising and appealing because you think of these risks as stable from birth. So being able to find this tool early in life and see the crystal ball for the future to conceivably primarily prevent these episodes is very appealing. However, in practice, the performance of these has been not the greatest. And using the example of polygenic risk scores, where we sum up lots of individual risk across the entire genome into one overall disease score. So for this case, cardiovascular or arterial disease. You see that the same score underperforms in women compared to men, with the odds ratio being only 1.9 for women versus 2.2 for men. We've made some progress in trying to address why we see these differences by looking at genes and specific risk markers within the genome that might be different between men and women. But whether these shed light into biological mechanisms is still unclear. And so we're stuck looking at these traditional risk factors that have been present for many years when we think about heart disease risk in both men and women. These are clinical conditions, so things like blood pressure, high cholesterol, diabetes, obesity, as well as lifestyle things. So smoking, diet, exercise, and stress are the main ones we think of. It's important to note that even though these are present in both men and women, they disproportionately affect women in many ways. So, for example, hypertension is a leading cause of cardiovascular disease, but in women, hypertension has a higher population-adjusted cardiovascular mortality compared to men. Furthermore, women are less likely to be treated to guideline-directed blood pressure goals. And on top of that, postmenopausal women lose the protective effect of estrogen, so they're more likely to have high blood pressure on top of not being treated to goal, on top of having a worse cardiovascular outcome from this. So it compounds on top of each other. Furthermore, there are many sex-specific or female-specific risk factors to consider, including those related to pregnancy. Adverse pregnancy outcomes like preeclampsia are now well known to link to adverse cardiovascular outcomes and cardiovascular mortality in the long term, with earlier and worse preeclampsia being associated with worse cardiovascular risk. Additionally, things like gestational diabetes which is defined as diabetes beyond the first trimester of pregnancy, is associated with diabetes later in life. So a sevenfold risk of diabetes, as well as a higher risk of cardiovascular disease, as diabetes after gestational diabetes is higher risk than diabetes alone. There are some conditions that are female specific, like polycystic ovarian syndrome, which is an endocrine disorder that typically manifests as infertility and hyperandrogenism in reproductive age women. We know that PCOS confers increased risk of cardiovascular disease, and one study showed that presence of PCOS had a fourfold increase in coronary artery calcification, which we use as a proxy for cardiac disease in patients with PCOS compared to those without in the general community. There are also increased prevalence of certain diseases in women compared to men. So systemic autoimmune disorders are a common one. These disproportionately affect women. Females are 2 to 3 times more likely to develop rheumatoid arthritis than men, and 9 times more likely to develop lupus compared to men. The chronic inflammation that results from these conditions is well known to progress cardiovascular disease and cause increased events, with the amount of flares that patients experience being directly related to the severity of cardiovascular disease later in life. Circling back to reproductive factors, we know that age of menarche, or the first period for young women, also plays a role in predicting cardiovascular risk. Interestingly, both early menstruation, so before 10 years of age, or late menstruation after 15 years of age, is associated with elevated risk, either 2.5 or 4.5 fold, respectively. And on the other end of the spectrum, we have menopause, which we know is a time point of inflection in terms of cardiovascular risk for women as we lose the protective effects of estrogen. Although we know there are many of these sex-specific risk factors, these differences have not been recognized in preventive screening and treatment guidelines. And so the clinical risk calculators that we use day-to-day in practice, and I'm showing one here called the ASCVD risk calculator from the ACC-AHA guidelines, really don't take into account any of those pink female-specific characteristics, and they focus more on those blue traditional risks. Therefore, it shouldn't surprise you at all when I say that the calculators underestimate risk in women. Here on the y-axis is the 10-year ASCVD risk, and the x-axis shows age in years. I want you to focus on the non-Black female curve in red and the Black female curve in green, both of which show that with other traditional risk factors held constant, the risk estimates are systematically lower in women compared to men, who are shown in blue and orange, respectively. This causes a marked sex difference in treatment recommendations. And at the midlife, that means that 84% of men aged 56 to 65 are recommended for statins, but only 29% of the similar women, so same age, same risk factor profile, are recommended for statins. We keep coming back to this midlife time point, and I know it's crucial because we are associating this with menopause. And the menopause transition, as I've mentioned, is marked by changes in endogenous hormones and most critically by fallen estrogen. This causes an increase in visceral fat and weight, as well as insulin resistance and worsened lipid profile that often culminates in a metabolic syndrome and even diabetes. The loss of estrogen also causes structural and functional worsening of vascular health, and that contributes to the higher blood pressure, the carotid thickening, and some of the vasomotor symptoms that are the hallmark of the menopause transition. Beyond being a marker of reproductive aging, natural menopause and age at natural menopause is increasingly thought of as a marker of biologic aging and also of general health. Later age at natural menopause has been associated with beneficial side effects such as higher bone mineral density, lower fractures, longer life expectancy, and reduced cardiovascular outcomes and reduced cardiovascular death. That being said, that menopause transition remains a really critical time point in women, and the incidence of cardiovascular disease rises dramatically at this time. You can see here with age on the x-axis and coronary artery disease incidence per 1,000 on the y-axis, that women, who are represented here in white, have a sudden jump in the number of incident coronary disease events starting at 55, which is around the midlife period. So even though we don't know the sex-specific factors, this is a critical window to address chronic disease prevention and try and optimize health and function of women. And the hallmark of cardiovascular risk reduction has really been lifestyle optimization to reduce cardiometabolic risk. These interventions, mostly behavioral-based to improve lifestyle, traditionally are delivered in face-to-face or group settings. However, with the advent of more of these digital health tools, we now have the ability to provide women, especially the midlife, with more portable tools to help enact and maintain positive changes. So I want to talk a little bit about some of the tools that are available on the spectrum, though I can't talk about the entire breadth of digital health in the confines of this talk. I'm going to focus on things that help promote patient engagement. These include text message programs and mobile health apps, wearables, which include physical activity trackers, EKG monitors, and biosensors like continuous glucose monitors, which are increasingly prevalent in both disease populations as well as healthy individuals. I also want to talk about more medical devices like thermometers and blood pressure cuffs that have Wi-Fi and Bluetooth capability, which combined with telehealth and EHR portals are moving us from this episodic in-person care to more of a continuous virtual spectrum. Finally, we have a lot of clinical decision support with prompts in the electronic health record and these risk calculators that have become very sophisticated with branching logic, not just about predicting risk, but individualizing treatment benefits so that patients can really understand the benefit or the risks of various treatments that are being offered to them. Finally, artificial intelligence is showing a lot of promise as an integration tool to combine a lot of these large data streams that are coming our way. It's going to help us derive some novel biomarkers in the future and potentially help us scale care delivery in a more cost-effective way. Before I get to that, though, I want to take a look at mobile health apps in particular. You may not think of your smartphone as a biomedical device, but given the number of apps in the App Store that are focused on health, I would argue that that is something that would be worth changing your mind on. Almost 1 in 3 physicians surveyed in 2021 responded they had prescribed or recommended a mobile health app to their patients. And a 2015 study that looked at the type of health apps patients were downloading showed that 85% of these apps relate to health maintenance or chronic diseases. A 2018 study following up on this showed that these apps reduced rehospitalization, improved patient knowledge, quality of life, and psychosocial well-being in addition to managing the CVD risk factors. And nowadays, 1 in 10 of these apps can link to sensors or devices to really have better biofeedback to improve functionality and convenience of using them. When patients ask me, given how many options are out there, what to look for in terms of successful app adoption, I tell them to look for things like simplicity. So simple designs that make it easy for a variety of tech savviness in terms of user benefit, and to look in terms of evidence-based information and credibility that the app is built on behavior change concepts rather than just a random app developer. Social elements such as gamification, which is allowing users to compete with friends and strangers on scoreboards or device-specific game centers, as well as virtual positive reinforcement using AI or a health coach to help promote patient interaction and engagement, helps patients feel that they're getting feedback and keeps them involved for longer. Similarly, real-time activity tracking, so using those sensors or wearables to input data rather than putting the onus of data entry and input on the consumer or patient, helps make that easier to maintain long-term. Finally, I tell my patients to keep an eye on the privacy assurances because these are direct-to-consumer products. They're not necessarily subject to the same strict HIPAA regulations that we normally think of as governing health information. In cardiology, the other big group of apps or devices that we use are wearables. This is most often seen in the arrhythmia field with AFib studies, such as the mSToPS randomized control trial and the Apple Heart study, both showing really great fidelity of these devices in diagnosing new atrial fibrillation. Unfortunately, though we can diagnose it early, this hasn't changed anything in terms of patient benefits and outcomes or decreased morbidity or mortality in atrial fibrillation long-term. And in heart failure, another subsection of cardiology, the levels have been even more mixed. This might have to do with the heart failure population being very heterogeneous, but also has to do with the telemonitoring interventions and the study designs being very different across different studies. So the device has to use the team composition being a non-healthcare professional versus a cardiologist, and the intervention being passive text messages that might be ignored versus a cardiologist changing prescriptions based on your blood pressure cuff make a very big difference in terms of the outcomes. And it makes it hard for us to compare these studies head to head as it's not apples to apples in terms of methodologies. One other type of wearable that we've shown promise is the continuous glucose monitor. And we've seen that the time and range that we have is inversely associated with long-term heart disease risk, like all-cause and cardiovascular mortality. So better glycemic control does seem to lead to better cardiovascular outcomes. And there are a lot of studies looking at whether this translates to more hard clinical outcomes like lower readmissions or heart hospitalizations for heart attacks. I tell my patients that the most tried and true tested area of wearables is as activity trackers. So we have a lot of randomized control trials and data showing that they excel in this sphere, especially as a short-term exercise supplement. They're very strongly linked to increases in step counts and increased energy expenditure. Typically, this is a modest increase, so about 1,800 to 2,600 steps per day more when you adopt a wearable than before. And that might seem daunting when you look at this 2023 study from Anyway at All, saying that 8,000 steps per day is what you need to have a decrease in your all-cause mortality. But when you look at this graph on the left side, you see that only 1 to 2 days per week is sufficient to have a really nice reduction in all-cause mortality in women. So I argue that having an activity tracker tell you when you're close to be able to push you over that 8,000, or even if you're not close, to push you to doing more than nothing is still beneficial. And so the activity tracker can act as a great motivator. The big criticism in this section is that the devices are very poorly retained past 30 days, and most people don't keep up with them long term. The single exception to this seems to be when the devices are implemented or followed up by clinical professionals. And we've seen that in our studies at Mass General as well. This creates what we call a patient, physician, and device relationship, where the adoption and retention of health tech is higher if it's suggested and monitored by clinicians that the patients are familiar with. And as studies are being based around specific interventions in specific populations, physicians are more comfortable in recommending those apps in those populations. Health systems are also getting in the game by buying some of the startups or developing these apps themselves to then better integrate them into more traditional care pathways. So we're going to be interacting with these one way or the other. The trick for providers is that it's not easy to tell the accuracy or the benefits for different apps and devices, and this is a very rapidly changing field, so the half-life of information is short. Therefore, I tell people the best way to stay informed about what's coming out is to be involved in the development and deployment within your own healthcare system so you have a sense of what's out there and the relative accuracies of them. No matter where you end up, healthcare and life has become extremely digital. And this was spurred on by the pandemic, but now that the cat is out of the bag, it's unlikely that we're going to return to a more analog way of life. Our expectations of healthcare and digital health are shaped by non-healthcare experiences. The services offered by Netflix, Amazon, and Apple, where you have device interoperability, you pick up in one place, you start watching in another place, makes it very seamless and streamlined and easy to deal with. And you come to healthcare and you have to pick up a phone and ask your primary care to fax your records to your specialist because the EHRs don't talk to each other. It creates a very jarring and unpleasant feeling working with healthcare, which has been somewhat lagging behind. But as we start to proliferate in the apps and devices and solutions, it's important that we don't fragment the system further and focus a lot on interoperability, as well as meeting these expectations of simplicity and scalability to avoid overburdening a healthcare system that's already a little overburdened to begin with. We know that there's a large appetite for these, so we have to be careful about how we implement them. And specifically, women have shown a large propensity towards using digital health. They were already controlling 80% of the healthcare decisions, and we spend 29% more per capita on healthcare. Women are more likely to use digital health technology, and they're actually more likely to be super trackers, which means they use more than one type of technology. And this has led to the advent of something called femtech, which are applications and devices specifically targeting women and looking at women's specific conditions like fertility, menstrual cycle, and menopause in particular. And I think this is a really great development because it's one of the few times that women-specific devices are soliciting women feedback to really make these products specific for women. This has been a marked contrast to the gender data gap that we've currently had in healthcare to date. So cardiology is no exception. And we have 51% of patients who are women in cardiovascular disease, yet only 39% of cardiovascular clinical trials have female participants. And so we end up in a situation where we call women's chest pain atypical just because it's not like men. We end up with clinical risk calculators that underperform in women because they're calibrated for men. And so though we talk about AI having the potential to transform cardiovascular medicine, it's also concerning because it's shown to have racial and gender biases in other situations. So it could potentially reinforce inequalities and magnify these patterns exponentially unless we really emphasize that the participation of women and other underrepresented populations to make sure the technology is equitable going forward. So to wrap up a little bit, I know I've talked about a wide variety of digital health devices that are available, and it might seem daunting or overwhelming to try and find the correct tool or the correct utilization. I think you do need to think about it as an investment, both in time, patience, and money to find it, but also need to reframe the thinking from being one product that's going to be superior to others to thinking about using multiple products at different points. I like to think of digital health tools as shoes. The different shapes and styles fit differently depending on your day's needs. So a woman who's in their late 60s has different physical needs and psychosocial needs than a woman in her early 30s. Similarly, the barriers to behavior change look different for someone who's already achieving 60 minutes of moderate to vigorous physical exercise per week versus somebody who's doing 10 minutes or 0 minutes per week. So a collection of connected tools provides a flexible system of care, and though it requires some individual shopping around, gives you an option for a toolbox to pick different items at different points in our lives. So just to reiterate the main points in my talk once more, we discussed how the menopausal transition is a marker of biologic aging and accelerated risk, with midlife being both a vulnerable time point but an opportunity to enact durable risk reduction. These lifestyle changes are aided by the judicious use of digital health interventions, but the exact best tool is going to vary from person to person. In future, it's critical that we have female representation in digital health clinical trials to avoid creating or worsening gender disparities in care, worsening biases or outcomes. With that, I'll wrap up, and I thank you for your attention. I look forward to hearing your questions soon.